I have two cases to present. The first was a case of a twin pregnancy with Hydatidiform mole and a normal fetus. And the second was a partial mole with multiple congenital anomalies. The first case was that of a 40-year-old grand multipara who was unsure of her death. For an abdominal examination, the fundal height was equivalent to 21 weeks of gestation. She presented with new onset epistaxis and has been bleeding per vaginal for close to 4 weeks. Ultrasound revealed an apparently normal upper twin assisting with gestation with a molar lower twin. The placenta of the normal twin was fundal and grade 0. The ultrasound diagnosis was complete molar pregnancy coexisting with a normal fetus, but histopathology confirmed that it was a partial, not a complete, mole with a lower twin. These are the still images. As you can see, this is the fetus, apparently normal, with its normal placenta and the molar tissue. And this is the dual image showing the typical honeycomb or snowstorm appearance of the molar tissue, the normal placenta, and the apparently normal fetus. Again, this is a dual image showing the molar tissue and the normal skin, spine, anterior abdominal wall, intact chest. The same in this enlarged image with the normal placenta. These are also different views depicting the normal placenta, the molar tissue, the apparently normal fetus. This video was taken using a handset, and as one can see, the gain is high. This is the bladder, the cervix, and here is blood clots in the lower portion of the uterus. Remember, the patient has been bleeding for 26 days. So this is blood clot. This is the molar tissue. Note the marked demarcation between the blood clot and molar tissue. This is a normal placenta here. Look at the breach between the normal placenta and the molar tissue. Live fetus with regular cardiac activity, apparently normal. Again, blood clots, the molar tissue, the typical snowstorm or honeycomb appearance. This was the placenta of the normal twin, and this was that of the molar tissue. The second case was that of a partial Hydatidiform mole with congenital anomalies. She was 35-year-old, gravida 8/7, who presented with severe lower abdominal pain at 4 months. Her pulse volume was 23%, and the blood pressure was 158/180 millimeters of mercury at 4 months. These ultrasound images were sent to me by a colleague for a second opinion. When I made the diagnosis of a partial mole, I requested him to send me the ultrasound images and the images of the placenta after expulsion, and he gladly did so. Here you can see the ventriculomegaly and what looks like the banana sign of a deformed cerebellum. This is the gross specimen of the molar tissue, clearly seen here as the molar vesicles, the typical hydatid mole. Here you can see the spoke wheel appearance of thecal luteal cyst, and this probably explains the severe lower abdominal pain she presented with. Not the open spina bifida. Because of the open spina bifida, CSF would leak into the amniotic cavity, and that will lead to hypertension in the subaqueous space. This will lead to caudal displacement of the brain and obstructive hydrocephalus, as is seen here. So this is obstructive hydrocephalus, and this, although not a good view, is the banana sign of carry 2 malformation. Here you can see the multiple anomalies. If you draw a line here, look at where the ear is. Low set ear, increased knuckle fold, open spina bifida, retrognathia. So now looking at this line diagram to explain the ultrasound features of retrognathia. Here you can see this is the mandible. This is the nasal bone, and here is the maxilla. Now on this image, you can see the nasal bone here, the skin, the tip of the nose here, the maxilla, and the mandible. And this is the intracranial translucency. Now here the maxilla appears as a single bone, but actually the maxilla is not a single bone. This is because of the resolution of the machine, and this was a transabdominal image, and also it's a still image. Now the maxilla is made up of the vomer bone, the secondary palate, and the premaxilla. So this constitutes the maxilla. This is what is typically called the superimposed line sign. Now if we draw a line that crosses the tip of these bones, the nasal bone, the premaxilla, and the mandible, you have what is called the frontal space distance. In normal situations, this is what you have. And here again, if you trace from the mandible through, this is the frontal space distance. If there is receding of the mandible, this space would increase. So if there is receding of the mandible here, this space here would increase. So in this case, where you have either a micrognathia or retrognathia, what we expect on ultrasound is for the increase in this frontal space distance, although it can also be increased in bilateral cleft lip and palate, where this premaxilla will protrude forward. This maxilla will protrude forward. Here you can see the open spina bifida, and this is a transverse section of a normal spine. Here you can see a normal skin. In this case, you will not see a normal skin covering this area. Here you can see the posterior elements converging towards the midline, giving a V-shaped appearance. In open spina bifida, these posterior elements will diverge and give a U shape rather than a V shape appearance. These are other indirect signs of open spina bifida. Obliteration of the intracranial translucency. Here you can see the intracranial translucency. It will be obliterated because of the caudal displacement of the hindbrain. You see a single line instead of these two echogenic lines. You see a single line. The banana sign we've seen, the lemon sign. Increased brainstem occipital bone distance, parallel cerebral peduncles, aqueduct of sylvius to occipital distance, maxillo-occipital line, ratio of correct produce to head size, expanded correct produce in the first trimester, which gives what is typically called the dry brain, and dangling choroid produce in the second trimester, biparietal diameter less than 10 centile at 11 to 13 with scan, and crash sign. All these are indirect signs of open spina bifida. Now, this is a normal case. In a normal case, the posterior fossa is normal. At the level of the foreventricle here, you can see the foreventricle, the cerebellum, the vermis, the cisterna magnum. All this will be seen. But because of downward displacement of the hindbrain midbrain complex, in cases of open spina bifida, because of leakage of cerebrospinal fluid, one will pick the typical banana sign and also the lemon sign, which are indirect cranial features of open spina bifida. So, in this case of open spina bifida, this is the intracranial feature that is expected in this case. Here you have cystic closed spina bifida, and here you have non-cystic closed spina bifida. In this case of cystic closed spina bifida, the posterior fossa will be normal. Why? Because there will be no leakage, so there will be no Chiari malformation. This is a case of closed spina bifida. In this case, the posterior fossa will be normal because there is no leakage of cerebrospinal fluid. Thank you very much.
Desafío